Good afternoon, everyone. First of all, I would like to thank Dr. Jyotikin and sir, Dr. Vilesh sir, and my friend Dr. Sonu for giving me this platform for discussing these points with the various students and dialysis technicians working all over India. I'm going to the topic. The topic assigned to me today is regarding the vaccination. The two main vaccinations that is given to our dialysis patients. One is Hepatitis B and another one is pneumococcal vaccine. As you all know, dialysis patients are already immunocompromised. That is, they are more prone to infections, and these infections will be producing more severe diseases than the normal populations. So we need to prevent getting infections for these patients, especially that lung infections. That's so annual pneumonia vaccine, including pneumococcal, is recommended for dialysis patients. Also, blood transmitting products, infections like hepatitis B, we have to be prevented. So there is a schedule for hepatitis B vaccination. So today I am dealing with the normal protocols in hepatitis B and pneumococcal vaccination, and also along with what are the newer researches and the upgradations going on in that. After that, I will have a discussion regarding the practical problems you people dealing with while administration and giving the patients, and if they are missing the doses. So you can ask those questions after on. Today, first I will deal with the theory part. So going to the one, first I will tell regarding the evolution of pneumococcal vaccine. All know the first vaccine was started in 1983 as a polysaccharide vaccine, 23. So polyvalent polysaccharide vaccine, it is initially given to minimize the infection of pneumococcal infection. Initially recommended as the single dose for adults over 65 years. That is, above 65 years, people are more prone for infections. And later on in 2021, and PCV13, that is pneumococcal conjugate vaccine was started. That is, it is Prevnar 13. It became widely available. This is conjugate vaccine, and more pneumococcal serotypes are covered, including invasive disease. So more protection than the classical PPSV23. So then recently, in the last 4 or 5 years, we got another two vaccines. That is newer pneumococcal conjugate vaccines approved for dialysis, that is PCV15 and PCV20. Same like 13, it covers more conjugate vaccine protocol, so it will be covering more diseases. It is not widely available. In the coming years, it will be widely available. Currently, it is only available in US and Europe. Strategy. Slide is moving.
It's moving. Slide is moving again.
Regarding current pneumococcal vaccination strategy, first just listen these points. Finally, I will describe how to give the vaccine and all. Currently, initially it was PSV 23 only. It is only given for people above 65. And initially we have given, later we have given PCV 13, then it was PCV 15 and 20. This is the vaccination protocol. There will be 5 scenarios. First one, people have never received either conjugate vaccine or polysaccharide vaccine. So if you, in that scenario, if you have availability of PCV 20 or 15, you give that one. And followed by PPSV 23, minimum of 8 weeks after that. If none is available, then you can go for PCV 13 first, followed by polysaccharide vaccine 23 8 weeks later. If no vaccination given, nothing is given, then you can give first PCV 20, and if it is not available, you can give PCV 15 followed by BPSV 23 after 2 months. If none is available, first you give PCV 13, then followed by PPSV 23 after 2 months. In the second scenario, if the patient received PCV 13 but not PPSV 23 in the past, then you can administer PPSV 23 if they have 2 months passed after giving PCV 13. Then another dose has to be given 5 years apart if it is below 16 years of age. In all these scenarios, if you have PCV 20, single dose of PCV 20 is enough. No other booster dose or anything. That's the advantage of PCV 20 that coming slides I will discuss. So these two scenarios I think you will be understanding. The third scenario, the patient has received PCV 13 and last PPSV 23 was given after. In that scenario, we don't need to give another booster dose. In the previous scenario, if they have given PCV 13 and PPSV 23 given after 2 months, and again another after 5 years, which is age is less than 65, you have to give another booster dose. If age is more than 65 years, PCV 13 plus second dose of PPSV 23 after 2 months is enough. It's the third scenario. Then fourth scenario, he has not received the PCV 13, but only one dose of PPSV 23 was taken. In that case, if it is he has taken already 1 year past after 23 taken, then administer PCV 15 or 20. If not available, PCV 13. If not past more than 1 year, less than 1 year, wait for till 1 year and then give PCV 13, 15 or 20. Okay. So in that case, you have to give PPSV 23. Along with that, 1 year later, we have to give add-on PCV 13. So salient points to be remembered are, and Prevnar 15 or 20 vaccine is only given once in a lifetime for the patient. And PPSV 23 can be given as many as maximum 3 times in the lifetime of patient. And 1 dose of Prevnar 20 will complete patient's pneumonia vaccination. Same like 1 dose of Prevnar 15 will require another dose of PPSV 23 to complete vaccination series. And Prevnar 15 or 20 vaccine cannot be given up to a year after receiving PPSV 23. PPSV 23 can be given as early as 8 weeks after giving Prevnar. So if age is above 65, only 1 dose of PPSV is necessary. These are the main points you should be remembering. It will be a little bit confusing, but if you remember this chart, so you can take photo or something, you can remember this chart and you can easily follow the guidelines. This is regarding pneumococcal vaccine, and in this administration usually PCV 15 and PCV 20 and PCV 13 are given only IM given, and there is a pre-filled vaccine which it includes 0.5 ml of the vaccine, and PPSV 23 can be given both IM and subcutaneously. It's also same dose like 0.5 ml. So next one, I'll be dealing with the Hepatitis B vaccine. As you all know, there is 3 formulations of Hepatitis B vaccine are available worldwide. The first two are the traditional ones, and the third one is the newer one. And the first one is that is Recombivax And first one and second one, that's Engerix and Recombivac's, both are created with the recombinant DNA technology from yeast, and both contain aluminum as the adjuvant for enhanced immune response. And the third one, that newer one, is Hepatitis B, that is brand name is Dynavax. This new formulation featuring another add-on protein including hepatitis surface antigen, that is CpG technology. And this represents a advancement in hepatitis B vaccination for especially immunocompromised patients. That doses and all I will tell in coming slides. So this is coming about the new points on the Hepatitis B new vaccine. It is a revolutionary advancement. It's 2017 FDA approved in the United States, and 2021 and European Commission also approved for giving in patients. And key advantage is novel immunohistostimulatory adjuvant. It has a CpG moiety that activates the immune response through toll-like receptor activation, TLR receptor TLR6. And it has only 2 doses required, only 1 month apart, and reduces the administration burden for the patient. And the CDC and the ACIP recommendations specifically cite serology testing 1 to 2 months after the second dose for hemodialysis patient to confirm adequate response. And the response criteria, if an anti-HBs titers are inadequate after second dose of series, patient should receive additional doses rather than repeating the complete series for this coming patients. Okay. So this is about the newer revolutionary hepatitis. It's comparing to the previous hepatitis vaccine. It's higher antibody response with than with 3 doses of hepatitis B CpG compared to the 4 doses of Engerix vaccine in CKD patients. And CDC and ACIP recommend the 2 doses followed by serological testing. Repeating the second dose if needed, simplifying the vaccination protocol considerably. And this wide availability is the main issue. Only available in the US. It's not available in our country. Okay. Coming to the clinical algorithm and framework for the vaccination of CKD patients. Here I am talking about each bit of off-dialysis patient also. So initial all CKD patients require screening, especially progressive disease with eGFR less than 30 or facing immunodialysis and transplantation. And they should be assessed before going for treatment, especially before dialysis and all. We should screen the patient and look for a negativity or anti-HBs titer, and we should go for vaccination. And pre-dialysis CKD vaccination options, they have 2 options. One is preferred adjuvant vaccination. That is, first one is Hepatitis B, that's only available in the US. It is 20 micrograms, 2 doses, 0 and 1 month. It's the gold standard whenever available and affordable. And second is the standard one, 20 micrograms, 4 doses, 0, 1, 2, 6 months apart when they are available. Some people they are giving enhanced conversion regime in pre-dialysis patient itself, like 40 microgram double dose at the same scheduled months. And accelerated schedules will give some people if they are planning for impending dialysis need or planning for a transplantation and all, can give it a 0, 1, 4 and 8 weeks. That is first 2 months itself we can complete the vaccination. These are the 2 things we can give in pre-dialysis vaccination options. And advanced vaccination, like similar to one, we can give the same one. And those should be doubled when compared to the previous one. And Hepatitis only 2 doses required, but the other one is we need 4 doses, 0, 1, 2, 6. When coming to the vaccination response and management, the overall response rate in vaccination to vaccination in the dialysis population with standard regime is only 70%. It is significantly lower than the healthy population. Then second series of vaccination is indicated if seroconversion does not occur after initial series. This provides an additional opportunity for immune response. Some people, after checking after the vaccination, there will be no adequate antibody response. So we may have to give a second dose of vaccination. The schedule and all I will tell you in the coming slides. There is no, if the second full hepatitis B vaccination series fails to induce antibody titer of more than 10 milliunits per ml, then that is known as non-responder. In that non-responder, we may have to go for newer vaccinations, or we have to serially checking HBsAg titer and HBsAg in those patients and reduces the risk of explosion can be done. And the emerging solution is the new Hepatitis B vaccination. So what is the universal post-vaccination monitoring protocol? Actually, annual testing is required for the HBsAg titer, antibody titer, and administration of booster vaccine when available. Antibody titer drops below 10 milliunits per ml to maintain protective immunity level. And testing should be done actually a minimum 2 weeks post vaccination. And universal testing. All CKD patients require anti-HBs level checking 1 to 2 months after completion of primary vaccination series. So we should give the vaccine either that more normal regime, accelerator regime usually will give 0, 1, 2 and 6 months. Then once completion of vaccination is over, after 1 or 2 months, we should check the anti-HBs titer. And then annually we have to check. If anti-HBs titer is below 10, we have to give another booster dose and check for response. Okay. And response after for checking response, there should be minimum of 2 weeks post vaccination. So already know the response based management strategy. Responders means if anti-HBs titer is more than 10, so annual monitoring is needed. And good response means there should be more than 100 milliunits per ml. That's a good immune status. So if there is weak response, like between 110 to 99, for CKD patients, we may can try for another booster dose rather than continuous, another complete regimen. We can give another booster dose for CKD patients. So non-responder, revaccinate with complete second series, preferably with a different and more immunogenic strategy, and switch to other vaccine like Hepatitis for 2-dose series for enhanced immune stratification. So coming to this one, these two compared to the pneumococcal slides, you can have these 3 slides. The flow chart is there. From this you can understand all the problems. For initial screening, all CKD patients, including dialysis, and all patients perform all these and HBsAg, anti-HBs, and anti-HBc. If pre-dialysis, you can give, if Hepatitis is available, you can give, or you can give conventional vaccines like same schedule. On advanced stage dialysis, high likelihood. So if the Hepatitis is available, you can give that, like 0 and 1 months. And if it is not available, you can give accelerator regimen, give double dose, 0, 1, 2 and 6 months. Now all these vaccines are IM. And check anti-HBs level 1 to 2 months after completion of primary vaccination series. Responder means monitor HBs annually. And if it is less than 30 ml, 10 ml, consider adjuvant vaccine. So same for booster dose. Non-responder, you can give another type of vaccine, again for 1 full course, or newer vaccine can be tried. Special population like pediatric and transplant patient require after 3 to 6 months of stable intensive immunosuppression only you can give for adjuvant or high dose vaccine. Pediatric age group also we have to give according to the patient's age and weight category. So simply putting this, if no previous HBsAg vaccine, this vaccine, if the newer Hepatitis is available, you can give for that. Go for that with 20 microgram, 2 doses 1 month apart. And after that, if you check HB titer after 2 months, if it is positive, continue monitor yearly. If it is not positive, you can give 2 more doses. We repeat the same vaccine and then check for anti-HB titer. If the HB is not available, we'll directly go for HB titer. If it is positive and previously vaccinated, we can monitor that. If previously not vaccinated, then go for the standard one regimen, that's Engerix or Recombivax, and wait for after completion of this one, and again you monitor this yearly. If no previous vaccination is not available, also go for the same. Okay. This I complete my slides. Thank you for the question listening.
I would like to thank Akhil for that comprehensive discussion on both hepatitis B and pneumococcal vaccination. At present, as I believe, we have availability of only normal Engerix and other vaccinations in India as of now. So I'd like to request the audience for any questions that they have, and they can post that in the chat box or just unmute and ask yourself.
Sir, is that any age category for pneumonia vaccination, sir?
Which one?
Which age category has injured by pneumonia vaccination, sir?
Insured by for hepatitis vaccine?
Yes, sir.
More than 18 years, they are telling. For newer one.
No, Mr. Vincent, this class doesn't have any certificate. And we would like to highlight that the vaccination is very important because as early as in the CKD, as we immunize, the seroconversion or we are giving something which is similar to the virus or the bacteria, and the body is producing the antibodies to that. So if the body doesn't have the immunity, body may not be able to secrete produce the antibodies. So that essentially is seroconversion, production of antibodies against the virus or the bacteria. So what happens when this virus or bacteria comes into contact with the body later? This already formed antibodies will go and neutralize them and prevent them from causing a serious infection. So we all know that our dialysis patients are fragile. So once we have this reaches a stage of ESRD, the seroconversion is limited. So it is easier to immunize the people once they reach CKD stage 3 or so, and to have the vaccination done as early as possible. In that scenario, what we do is we give 1 ml each deltoid. But our issue when the majority of the time the patient crash lands, we start on dialysis, then only after 2-3 days only we remember that the patient needs the vaccination. So at that time, patient might already have a fistula done or in one hand. So if the patient is not is already having a fistula, then they can be given vaccination on the non-fistula hand. In the non-fistula hand, then what we do is that the two vaccines are given simultaneously, and it has to be given at least 30 minutes prior to 15 to 20 minutes prior to the initiation of HD. So that post-HD, the patient will already be heparinized. So the chances that the patient can have bleeding is there. So the vaccination has to be done pre-HD. We have few questions in the chat box. If a person never responds to any kind of vaccination, what is the protocol like giving GMCS of prior?
First question was how much hepatitis B vaccination should be given in the lifetime. Actually, I told that two types of vaccine, standard, recombinant and newer one. Standard recombinant is 0, 1, 2, 6 and the newer one is 0 and 1 month. This is a one schedule. So according to the guidelines, first you vaccinate the full schedule. After 1 month completion, you check the antibody titer. If it is less than 10, that means non-responder. Then you can give another, again you can vaccinate with the same medicine or with another molecule. That is complete that dose also. So two vaccination complete. Again, if you check anti-HBs titer, if it is less than 10, that is non-responder. In that case, in those patients, especially in dialysis, there is no definite guidelines. According to the literature, they told you have to just follow up the patient at least 3 monthly for both HBs, ELISA and also with the anti-HBs. And if patient is developing the disease, you can treat. There are no definite protocol for again second vaccination, third vaccination. In lifetime you can give 2 vaccinations. If newer vaccine comes, you can try that one. That is regarding lifetime.
There is no protocol, as I believe, to give GMCS of prior.
No, nothing is there. Nothing is there. So is there any immunocompromised medicines like steroids or any other active medicines we have given? You should wait for at least 8 weeks before giving this vaccine.
Previous, if 1 or 2 vaccines, 0 and 1 has been taken, 2 and 6 has been skipped. In that scenario, what we will do, like restart the entire vaccination, or we will give only the remaining doses?
In 0, 1, 2, 6, if after first dose, if he missed the second dose, you can, whenever he remembers, give the second dose. Then 1 month later, give the third dose. Then you consider from the first dose, after 6 months you will give. Okay. Then between third dose and fourth dose, there should be minimum 2 month gap. 2 months gap should be there. That is the way. So after 2 months, 2 doses if you missed again. So if you are remembering on the fourth month. So that time you give the third dose. Then after 2 months you give the fourth dose. That will be completed. Again you check the anti-HB titer after 1 month. If it is less than 10, you give another booster that time.
Thank you. And regarding the sites other than deltoid, in a patient with a severe edema, we can give it on the thigh or can give it on the gluteals, like we do give for a normal IM injections. It's this thing. Any chance of allergic reactions? Not very severe, but can occur at times. Any chance of allergic reaction after getting vaccine? I have not. Personally, I didn't have any instances.
Actually, there also, usually it is recombinant vaccine, so there is less chance of allergic reactions. Very, very rarely they are telling some reactions for this adjuvants like aluminum they are using. For that some transient reactions, skin reactions will be there. No serious reactions till now recorded.
These are the 2 main vaccines which we give for our dialysis patients. Other than that, the additional vaccinations which can be considered as the annual influenza vaccine, which is for the virus coverage. And some people may receive additional vaccines such as herpes zoster vaccines and MMRs, etc. But majority of the time we do give only 2 vaccines, and one vaccine which has been very famously given recently was the COVID vaccine, but now we are not giving that also. So if there are no further questions, then I would like to thank Akhil once again for that comprehensive discussion on the vaccine protocols. And let us remember this, that the patient is getting vaccinated not only for their own benefit, it is for our benefit also, because the thing is that we do deal with the procedures too much. We come in contact with the blood of the patients too much during the dialysis procedure. And so one thing is that when we are having this much issue, we have to make sure that all our patients are vaccinated. And second thing is that you have to check hepatitis B titers at least once per year, and we have to check for hepatitis B and HCV and HIV biomarkers at least once in 3 to 6 months. So one recent issue that we have faced is that one patient, if a patient who was HDSG negative previously and now he comes as positive in the routine checking, what we do with the machine which has been used for the positive patient? Can it be again used for a negative patient like that? Ideally, that machine has to be down for 7 days, and it has to be given serial sterilizations according to a very comprehensive protocol. Then only it can be taken up for giving dialysis to negative patients again. So keep those in mind and check the vaccination status of all your dialysis individuals. And I would like to ask Akhil for any concluding remarks.
Okay, thank you for listening to my topic presentation. Main thing is safety of the patients and safety of our technicians. That our safety is the prime important. So we should be vaccinated. We should follow the standard needle protocols, and safety protocols should be maintained. And especially that currently they are telling there is no isolation for this hepatitis positive or negative patients in between. Mainly the isolation is given to prevent cross-contamination while handling the needles and the tubings. So you people will be mostly with the patients, so you should take care of yourself and the patients for the proper prevention of this transmission among these hepatitis disease in dialysis patients. Okay, thank you.
Thank you, Akhil. And I would like to thank George Nanan sir and Village sir once again for this opportunity for both of us. And I would like to hand over the session to Vaishnavi. The NCure has been phenomenal in supporting the academic initiatives of the ECNG. I would like to thank the NCure people for that. And Vaishnavi, concluding remarks, please.
Yes, sir.